Hi, this is Brian Kim. I'm going to share with you this case. This is interesting. In this case, I had to use two different Phaco handpieces that malfunctioned. The first one malfunctioned, and then the second one malfunctioned. But I decided to proceed with the case, and I'll show you kind of what happened and my rationale as to why I proceeded with the case, despite the handpiece not working properly. I used a corneal mark to help me size and center my rexus. I make my paracenteses incisions, and then I'm injecting intracameral lidocaine. I fill the eye with dispersive viscoelastic. I do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I perform my puncture style capsular rexus. I use the forceps to puncture and then pull down into the subincisional area, creating a little bit of a C-shaped flap, pushing it a little bit to the right. I grab the flap and then go around and then re-grab as I need to, trying to ensure there's minimal viscoelastic coming out of the wound. I try to use the corneal marks to help me guide the size and center of the rexus. I burp some viscoelastic out of the wound and then do my capsular fornix hydrodissection, place the cannula out to the equator, point the cannula tip down, and then get a nice fluid wave that propagates, decompress on the left side, and then I start to spin on the right side, and you can see this happens very easily. I lift the incision with irrigation off. I go into the eye to minimize any Decimase trauma with a phaco tip. I remove the surface epinuclear material and then place the chopper out to the equator, turn the phaco tip vertically, crush the lens material with the double chop maneuver, separate the lens pieces, place the chopper out to the contralateral equator, pull it towards the middle, and this is the cross chop maneuver. This is when I start to try to use a little bit of phaco, and I also notice that the vacuum is not going at max. The vacuum has been reduced, the phaco is not working, and so I took the handpiece out, gave it to the technician, phacoed inside a container full of BSS, and I could see that the CDE was moving, but the vacuum was not elevating. It was a little bit stuck. I was going pedal to the metal, yet the CDE only showed 0.91, and the vacuum was dramatically reduced. So we went ahead and switched handpieces, and then went ahead and started to do my mechanical fracturing. Went ahead and fractured and cut this first quadrant, but then I noticed even though I'm using the high vacuum, there is absolutely no ultrasonic energy. The CDE is not moving at all. Remember, this 0.91 CDE essentially happened outside of the eye when I put the phaco tip in a cup full of BSS. And so you'll see throughout the case, there's no movement of the CDE of 0.91. And you can see on the screen that I'm going to foot position 3, and yet the CDE is not moving whatsoever. So at this point, I had a decision to make. And rather than switching handpieces again, this patient's already been sitting here for a little while, and our fluid is getting reduced in the bag. I decided to proceed. This is about a 2+ dense lens. I decided to proceed with doing cataract surgery with a handpiece that had no ultrasonic capability, just utilizing aspiration and vacuum. I've used mechanical fracturing forces and techniques to leverage removing and disassembling the lens, and then using the aspiration and vacuum to evacuate and remove the lens pieces once they're in small enough bite-sized pieces. So you'll see this case does not proceed as fast as it would have with phaco, but not by much. I'm able to remove the lens pieces methodically and carefully throughout this case by utilizing mechanical fracturing forces, once again, crushing the lens material between the chopper and phaco tip, repositioning the pieces using the vacuum, and then crushing again, successive crushing maneuvers between the chopper and the phaco tip to the point where the pieces are so small that I'm able to just simply aspirate and vacuum out the pieces. Here you can see the epinuclear material has been removed. I'm taking the chopper out of the eye. You can see that the CDE has not moved whatsoever throughout the entire case. I'm pushing BSS in the eye, taking the phaco tip out and switching it to the INA handpiece, doing my fluid exchange. I'm going ahead and do the INA removal. You can see that there's not much cortex left, and so I'm moving to the polish step fairly quickly, removing any lens epithelial cells on the anterior capsular surface, and then now on the posterior capsular surface as well. I'm going to do my subincisional capsular fornix flush with the BSS, and lo and behold, you'll see a bunch of cortical wisps coming out. I'm using the INA to remove those wisps, and then I'm flushing again. Again, I'm always amazed how much cortical material is left in the subincisional space in some of the cases. And so using the BSS flush has really been advantageous for me. I'm pushing viscoelastic into the bag and then switching to the sweep. I'm first sweeping to the left side and then to the right side. I'm injecting a single piece acrylic intraocular lens and then using the INA without fluid going into the incision and then turning the lens 90 degrees clockwise, getting under the lens and making sure I evacuate and remove all the lens material as well as the viscoelastic, and then removing the viscoelastic in the anterior chamber and then hydrating my incision. So you can see this case showed a 2+ dense lens. We had a malfunction with a handpiece. Rather than waiting and stopping and having the patient wait, I had confidence in the mechanical fracturing techniques, crushing the lens material between the chopper and the phaco tip, making the pieces into bite-sized pieces, and then using purely aspiration and vacuum to remove the lens pieces. So I think this is pretty convincing and a pretty clear indication that mechanical fracturing does work, and it's a very powerful tool that can be utilized by anyone, and you can reduce your CDE significantly in these cases, have clear corneas at the end of surgery, and as you can tell by this case, not only can you reduce CDE, you can get by with no ultrasonic energy at all in some cases. So I hope this was helpful to you, and thank you for your attention.